também participantes do Brasil e Portugal. Okay, let's start with greetings for my friends, Guilherme from Brasilia, Fabricio from Philadelphia, and actually Professor Marjana Reis from Porto Alegre. Okay, let's start with some rules about the webinar, some simple rules. Audio and video will be muted for all the assistants, and question and answers will be for via the chat box. And please stay tuned for this countdown. After that, we are welcome to my friend Guilherme from Brasilia to talk some tips about our course.
Hello everybody. Can you hear me well?
Excellent.
Okay. So just want to say a few words about our website that we would like you to visit and check all the information that we're posting in it. So at the home page we have all our brilliant speakers that are contributing to our course, and you can and then in the logged area we can see the videos that are already posted of our course, and also some brain tumor cases that are relevant to our courses. As you can see here, they are powered by PACSpin, and you can see the full cases, like this medulloblastoma WNT in a 7-year-old male. And you can check all the sequences and scroll down. We are posting every week. We're posting new lectures and new cases, so you can enjoy all our material. Also, the webinars that we're doing, they will be posted right after the live event, and they will also be posted in the YouTube in our YouTube page. Again, thank you very much for attending, and we will have a very interesting lecture by Marjana. I'll pass the word to Fabricio.
Thank you very much. Thank you very much for your presence. Thank you very much for your patience. Thank you very much for the audience. And we have friends from all over the world today. We have almost 100 people together. It's so great to be online and speaking about neuroradiology, something that we love to do. And I have the pleasure to have Marjana. Marjana is a great friend. She is a rising star in the south of Brazil. And she is a neuroradiologist. She works in two hospitals in Porto Alegre, which is a very interesting and very nice city in the south of Brazil, almost next to Argentina. And she works at the Moinhos de Ventos and Nossa Senhora de Conceição Hospital. And it's a pleasure to have you here today, Marjana. And for all the audience, please stay tuned until the very end, because we are going to provide you a coupon or a code for a special discount, so you can benefit from the amazing course that we put together. It has a great value. There's nothing in the market with this content so far. We have brought several excellent teachers, and our idea was to speak everything about brain tumors, either in children or adults. In addition to that, we have put an immense effort to bring a more clinical module. So you're going to have an experience about how to treat, how to deal with this sometimes deadly disease, but hopefully in the future, we are going to have more research and improvement in the treatments, so this can be treated and with a better outcome. But without further ado, thank you very much, Marjana, once again for your presence, and the stage is yours. Thank you very much.
Thank you very much. Can I share my screen here?
Yes, yes, we can.
Here.
Yeah.
Here. Do you guys see the presentation?
Not yet.
We can see you, but not your presentation.
And now?
It's coming up. It's coming up. Yes, excellent. Thank
That's
you very
okay.
much.
Okay, thank you very much. Oh, let me just. Okay. Can I start now? Do you guys hear me well?
Yes,
Please.
yes, yes, excellent.
Okay. Okay. So hello, everyone. First, I would like to thank the organizing committee for the opportunity to talk here with you about this subject. As Fabrício said already, my name is Marjana. I am a neuroradiologist from Porto Alegre, Brazil. I work at Hospital Moinhos de Ventos and Nossa Senhora da Conceição, which is part of Grupo Hospitalar Conceição. And today I will talk to you about the fundamentals of CNS neoplasms imaging, everything you need to know in order to achieve the best diagnostic hypothesis, and with linear knowledge and for, a way to think to make this diagnostic. Okay, so I have no conflicts of interest with this presentation. Okay, central nervous system tumors are one of the most prevalent diagnoses in our practice, and along with vascular diseases are responsible for high morbidity and high mortality in world population. So it's of main importance that we know how to accurately identify these lesions in order to diagnose correctly and help in treatment planning. These charts here are from Central Brain Tumor Registry of the United States, the CBTRUS, showing that between 2013 and 2017, malignant tumors accounted for almost 30% of the tumor cases, while non-malignant accounted for 70.3% of the cases. In this scenario, glioblastoma represents almost half of the malignant tumors, while the majority of non-malignant tumors, as you can see here in this chart, represented more than half of the benign tumors. And how us radiologists can be a part of it and help to establish a diagnostic hypothesis. There are some features that must always be considered while reading scans, which can be helpful in order to suggest the more accurate diagnosis. And they are in this table: age, location, the multiplicity, as if the tumor is single or multiple tumors, the proper imaging aspects of the lesion, and finally, to search for key findings that help to rule out mimics and pseudotumors. So let's start with age. And this is a diagram that I like very much that shows how age can head us in direction of correct diagnosis. Many tumors are distributed over age, and some of them frequently occur a specific age range. For example, let's start with the astrocytomas, which is this green bar here. They affect patients of any age, but we know glioblastomas are more common in older population, while polycytic astrocytomas are found frequently in pediatric patients and low-grade gliomas in children or younger adults. So we can see that there is a almost specific age range for us to think about certain diagnoses. Oh, I don't know what's happening here. Okay. And medulloblastoma is commonly associated with pediatric range here, while meningiomas and metastases, this blue here and red here, are much common in adults, with some exceptions, like when we have a pediatric tumor that can metastasize, but it is like exceptional. If we have a pediatric patient with a lesion that appears to be metastatic, we have to consider the possibility of neuroblastoma, because other tumors are not common to metastasize in children. And we have these two other charts here that illustrate the difference of tumor prevalence between children here and adults here, followed and metastases represent, as we said before, represent the vast majority among adults. As you can see here, half of the chart is metastases, followed by meningiomas, which this diagnostic is irrelevant in children. On the other hand, pilocytic astrocytoma and embryonal tumors occur expressively in this pediatric age range and are not that frequent in adults, as we can see here. With these image informations, we now see the importance of always looking for the patient's age in order to help suggest a diagnosis. So when you get a scan to read, always look for patient age and make sure this data is correct, because sometimes an error of this information can prejudice your diagnosis. Another important feature in tumor evaluation is the location and what there is to consider about it. We have another table here. Mostly what we have to consider is if it is intra or extraaxial, super or infratentorial, if it crosses or not midline, and the extension through the brain parenchyma. Now let's see a little more about it, and keep in mind this table. So one of the first things we have to try to find out when investigating a tumor is whether it is intra or extraaxial, because it helps determining tumor origin, which is crucial for diagnosis. I brought two different images here, and they are easy to know if they are intra or extraaxial, but it will not always be like this. So we have some rules and some hacks that we can use to try to find out better if this tumor is intraaxial or extraaxial, because this is crucial for the diagnosis. I like to say that this is the first question we have to ask ourselves when we open a scan and we are facing a brain tumor. First thing, age, and the first question, is this intra or extraaxial? After we achieve a conclusion, if this is intra or extraaxial, we can continue to look for other aspects. Because once we understand if the tumor comes from the parenchyma or, for example, from the meninges, we will be able to narrow our hypothesis. For that, there are some aspects to consider. So let's start with intraaxial tumors. They usually have parenchymal bases, like as we can see here in this image. They course with more infiltration of adjacent tissue than displacement, as we also can see here, and they cause tissue expansion and like thickening of the parenchyma where it is located, if it's in the brain parenchyma or in corpus callosum, for example. We usually do not see gray matter between the lesion and the white matter, but we gotta be careful with this because sometimes, depending on the location, it may vary and it can be a pitfall. Also, commonly, we will see narrowing of the subarachnoid space, especially because of this thickening and mass effect of the lesion in the surroundings. On the other hand, extraaxial lesions normally show dural bases, like this one we can see here. And meningioma, which is the most common extraaxial lesions, can even show some enhancement in the adjacent dura, also called the dural tail sign. This case here is a meningioma, but this is a T2, so we will not see the dural tail sign. But if we had the T1 post contrast in this case, probably it would show. And besides that, extraaxial tumors can cause more displacement than infiltration of brain tissue. Like we can see here, we have some edema, but the tumor doesn't look like it is invading the tissue, just displacing and compressing it. And also widening or displacement of the subarachnoid space can occur, and this lesion may cause osseous reaction when it is near some osseous structure, for example, remodeling or hyperostosis. But the most suggestive feature, in my opinion, is when the lesion forms a CSF cleft in its surroundings, and this cleft is usually formed between the lesion and the normal brain tissue, associated or not with some flow voids related to displaced bile vessels. So never forget to look for this CSF cleft because I think is one of the findings that will mostly help you. In this lesion here, we have a wide CSF cleft surrounding all the tumor. So it is very good to illustrate what I'm saying. Not always will be like this, this clear, but I suggest to you that you look for this CSF cleft. And so you have to be careful, because sometimes the tumor has like a high intensity in T2, and you can be mistake this intensity for the CSF cleft. So always be careful, but this is a good sign to guide you to discovering if the lesion is intraaxial or extraaxial. Another point to consider is the compartment where the lesion is located, if it is supra or infratentorial. We know that pediatric tumors are mostly located at infratentorial compartment, while for adult population, they aren't that common. So we have a difference in age range where the tumors mostly appear. So when you're reading an exam from a patient that has an adult age, and you have an infratentorial mass, it is important to consider always metastasis as your first option, since it is very common in this compartment. Here are another two tables that I like very much. And the most common infratentorial primary lesion in adults is hemangioblastoma, but it is not that frequent. Metastases are way more frequent than hemangioblastoma. So metastasis must always be included in this differential diagnosis, especially in posterior fossa, since they are also common in supratentorial compartment. Like we saw, they are responsible for almost half of the lesions, of the tumoral lesions in brain. So always consider metastasis in your differential diagnosis. But in adult patients, gliomas present, they have a great importance in the possibilities of diagnosis. As for children, although there are a variety of possible diagnoses in supratentorial compartment, and the most frequent tumors normally arise in posterior fossa. So if you have a supratentorial tumor, you have lots of possibilities, but they are not that common. Although infratentorial, you have less possibilities, but they appear more frequently. Now another point, we have some neoplastic lesions that are more associated with this behavior to cross midline through white matter fibers, especially corpus callosum, which is the greatest. And they can be called butterfly lesions because of this aspect, looking like butterfly wings in corpus callosum. And this aspect is mainly associated with glioblastoma and lymphoma, the most important lesions that will appear with this presentation. Like this example here, we have a butterfly glioma in corpus callosum. Note that we have a great component in right and left of the midline, making this appearance similar to a butterfly. Less frequently, and also we have this other case here, a lymphoma. Note the homogeneous enhancement that we can see in lymphoma. And less frequently, meningioma at midline can mimic this presentation too. Here we have an example. It's a dural-based lesion with components in the two sides of midline. Note that the lesion, it doesn't arise from the corpus callosum and it doesn't arise from the parenchyma, but because of the location, it looks like this butterfly aspect, but we can see here that the lesion has edema and is displacing and compressing corpus callosum. It's not a lesion that comes from it. But it is also important that we know that there are non-neoplastic lesions which also present that way, this butterfly aspect. Renal necrosis can appear like this, probably in tumors that are located in the corpus callosum. Tumefactive lesions of multiple sclerosis, and some infectious lesions like neurotoxoplasmosis. Here we have an example of a neurotoxo in an immunocompromised patient, compromising the posterior portion of corpus callosum and doing this butterfly aspect. So when you have this butterfly aspect lesions, always consider this hypothesis of glioblastoma, lymphoma, meningioma, and other tumor mimics. Finally, the last point about location, I consider important to evaluate the length of tumor spread in the brain parenchyma. If it compromises 3 or more cerebral lobes, either uni or bilateral, it is suggestive of gliomatosis pattern of spread, which is our case here that I brought to illustrate for you. We have this huge and very extensive lesion compromising occipital, parietal, frontal lobe, deep gray nuclei, and insula. Almost all right cerebral hemisphere here, this huge lesion. As of 2016, the WHO classification of tumors, gliomatosis stopped being considered a single entity to illustrate a pattern of tumor spread associated mostly with gliomas. Either they are IDH mutant or wild types. So always remember, when you have 3 or more lobes compromised, think about this pattern of spread of gliomatosis. Not more the gliomatosis cerebri, which was an entity, but this pattern of spread in the parenchyma. Now let's go to point 3. And the fact that a lesion is single sometimes does not say much about it, if it is benign or malignant or its histology. Obviously, it's not the case of this classic meningioma here, also with the dural tail sign, the homogeneous enhancement. But sometimes we can see a single lesion, and well, just the fact that it is single will not help us in other aspects. But when the lesions are multiple, it may favor some diagnosis. The first one we have to always have in mind is metastatic spread for multiple lesions. Always think about metastatic spread. However, there are some primary tumors that can also be multifocal. For example, multicentric lymphoma or glioblastoma, which can compromise one of or both hemispheres in more than one focus. And besides that, there are some diseases that are known to course with multiple tumors, as for example, neurocutaneous syndromes like neuroradiology type 2, that is related to multiple meningiomas, ependymoma, the vestibular schwannomas. This is an example of a patient with neurofibromatosis type 2 and multiple meningiomas in bilateral. Or also von Hippel-Lindau, which is another neurocutaneous syndrome that may course with multiple hemangioblastomas. So always think about first in metastatic spread, but we have all these other diagnoses that are possible. Now we arrive to the 4th point, where we will finally talk about lesion aspects itself. First, we talked about age, after the location, and after the multiplicity, and now we will talk about the imaging aspects. And because neoplasms are lesions that are rich in intracellular water component, normally they will appear how? Hyperintensity 1 and hyperintensity 2, just like lots of other tumor brain lesions. And like many CNS lesions can appear like this way, hyperintensity 1 and hyperintensity 2. This is so mainstream and consequently not very helpful for us to establish a possibility of diagnosis. So it is intelligent and mandatory that we have in mind which components can present differently, hyperintensity 1 and hyperintensity 2, to help us to achieve a diagnosis. It's more important and interesting that we know that a tumor can present with hyperintensity 1 or hypointensity 2, then we know that they are like the classic hypointensity 1 and hyperintensity 2. These two informations here, when they are different, they can help us more than the normal one. Some of the components hyperintensity 1 which are most likely to appear in our daily practice are first methemoglobin, as it is a product of brain bleeding. And we have this example here of hemorrhagic metastasis of breast cancer. Note that they have this hyperintensity 1. Also, lesions with high protein content, like any lesion that has this protein content, but some examples, Rathke cleft cyst or colloid cyst that normally course with high protein content. Lesions with fat, like lipomas, dermoid cysts, and other lipomatous lesions. This is an example of a lipoma. And we can always use the fat set sequences to confirm that it is really fat. Oops. Okay. Cholesterol also can course with hyperintensity 1 and melanin. which here we have this example of metastasis of melanoma. And we can see hyperintensity T1 even in primary or in metastasis of melanoma. And also paramagnetic metals such as copper, manganese, and gadolinium. And we have here an example of a gadolinium deposit in dentate nuclei of cerebellum in a patient which does lots of exam because it has multiple sclerosis. While we have these hyperintensity T1 cases, hyperintensity T2 substances that we have to also always remember. First, high cell density, which is of great importance when studying neoplasms, because we have some neoplasms that course with high cell density, like lymphoma, in this example here, medulloblastoma, and some glioblastomas that can have some islands or all the lesion with high cell density, and other possibilities that can show this high cell density with low or intermediate sign in T2. And also to help us to achieve this conclusion that the lesion is indeed with high cell density, diffusion can help. They generally have a low ADC value and can restrict in the DWY sequences. Also, calcium, depending on its concentration, can show hyperintensity T2. We have this example here of a 1p92K correlation glioma, where we can see the match here. We see the calcification in CT scan that match with the hyperintensity T2 areas in the MRI. Besides that, hemosiderin presented chronic bleeding and lesions such as cavernoma and other vascular etiologies. We have this bulbar cavernoma here. Also, high protein content, as we saw in hyperintensity T1, we can have in lesions that are high protein, like this raphe cleft cyst here, and also colloid cyst. Melanin also can present with hypointensity T2 and flow voids, where we can see in high vascular lesions, like hemangiopericytoma, which can show peripheral peripheral number of flow voids, also vascular malformations, and like a glomus tumor that can have that salt and pepper aspect. Other components are more associated with some specific diagnosis, and I'll show some examples for you now. Starting with calcium. The gliomas with 1p92K, as I said, codeletion or the so-called oligodendrogliomas are highly associated with the presence of calcification in the tumor. Also, when we consider extraaxial tumors, we have to have in mind the calcified meningiomas and craniopharyngiomas, which can also course with calcifications. And besides that, we have the pineal lesions. And in the pineal lesions, the location of the calcifications may suggest diagnosis. As example, pineocytoma tends to spread the calcifications to periphery, while germinoma will embrace the pineal calcifications. But remember, these lesions do not calcify, they just interact with the calcifications that are already in the pineal gland. In the presence of fat component, we have to think in lipomatous lesions, being lipoma the most frequent, but also dermoid cysts, teratomas, and other lipomatous lineage lesions. Here we have an example of lipoma in the near corpus callosum in the midline. About cystic component. Gliomas in general can frequently have cystic components, especially pilocytic, astrocytoma, pleomorphic astrocytoma, and ganglioma, which are solid cystic lesions. Also hemangioblastoma, which can show a similar pattern and is located in posterior fossa in adults. But sometimes also metastasis can have cystic degeneration. And here we have an example of a patient with lung cancer. Note the hypersignal intensity in FLAIR showing the edema. This was metastasis with this degeneration. And finally, when we have a necrotic component, that is areas without enhancement or that point the presence of lactate in spectroscopy, we have to always have in mind the possibility of glioblastoma, the lesion most associated generally with necrosis. as you can see here in these two examples. And besides that, we have to consider the possibility of lymphoma if evidence of immunosuppression. In patients that are immunosuppressed, lymphomas may generate central necrosis also. Enhancement is intimately related to many neoplasms, and in intraxial lesions may indicate a blood-brain barrier permeability dysfunction. Extraxial lesions will commonly enhance since they aren't covered by the brain barrier. So we do not expect a lesion that has the integrity of the blood-brain barrier preserved to enhance. But when we have this dysregulation, they may enhance, and this indicates that something is happening there. But in the extraxial lesions, this is more common, so we expect more. In gliomas, presence of enhancement usually will mean less cell differentiation and higher grade, with exceptions like pilocytic astrocytoma, glioglioma, and pleomorphic xendoastrocytoma, whose solid part enhance, and they have the cystic component associated, even though they are low-grade tumors, and so they will enhance because of particular characteristics of the lesion and not for the grade, not for the low differentiation or high grade of the lesion. And also some non-anaplastic lesions may commonly enhance, like subacute stroke, abscess, other infectious diseases, demyelination, for example. So lots of lesions can enhance in parenchyma. So the presence or absence of enhancement itself will not help you that much in your diagnosis. But some lesions will present with these unique enhancement patterns that are very highly associated with that diagnosis. And that, yes, that can help us narrow our hypothesis. Not the fact, the yes, no, the qualitative possibility of enhancement, but the pattern of enhancement will really help us. When we have this, let's start here with the solid cystic. So when we face a lesion with this solid cystic pattern like this, the solid part enhances and the lesion has a cystic component, and the cyst can enhance in periphery or not, we have to keep in mind some possibilities. And the main possibilities are pilocytic astrocytoma, pleomorphic xendoastrocytoma, ganglioglioma, and hemangioblastoma, which commonly appear in this aspect. So when we cross these characteristics with the pattern of enhancement with age of the patient and location, may improve the diagnosis. So always remember all the steps that we made through here and relate all of them to achieve the best hypothesis. Nodular enhancement is commonly associated with metastasis, especially if they are multiple. So pay attention to other characteristics also, like presence or absence of vasogenic edema. We have in this example here, lots of nodular lesions. This patient had breast cancer, so this is metastatic spread with this nodular pattern. Ring enhancement is commonly associated with high-grade tumors, mostly when we have central necrosis present, as is a halo of enhancement with the center without enhancement. This pattern is more associated with these high-grade gliomas, especially when the ring is irregular and heterogeneous. It favors more the possibility of tumor. Also, some metastatic lesions may show this ring enhancement. Like we can see here in this example, the patient have multiple lesions and this vasogenic edema that is disproportional in relation to the lesion size. So here it is a metastatic spread. And besides the metastasis, we have some non-neoplastic lesions that may show this ring enhancement, like abscess, but we will expect a more homogeneous halo. Demyelination, we will expect an incomplete halo sometimes. And chronic hematoma, hemorrhage in brain parenchyma can also show this pattern. Finally, there is another pattern that frequently associated with neoplasm, that is thick periventricular enhancement. And this pattern is mostly related to subependymal dissemination, as we can see here in the example. This subependymal dissemination may occur in gliomas, lymphoma, metastases, and others. One of the differential diagnoses for neoplastic possibility could be infection, mostly cytomegalovirus, but in that case, enhancement tends to be more thin and more regular. This example here, we have a lesion base here near the ventricle, and we see that the lesion shows enhancement here in ventricular wall. So we see this subependymal dissemination of one primary lesion. Finally, arriving in the fifth and last step, it is important that we try to exclude from our hypothesis lesions that can mimic tumors. Morphology can be similar, and some clinical aspects may help or may not help, but sometimes are punctual aspects associated with the clinic or the imaging that can help us in this matter. And here I have some examples of tumor mimics. This first case here, we have this lesion that has an incomplete halo of enhancement. And in FLAIR imaging, this lesion showed some edema adjacent. This is tumefactive demyelination lesion. This other example here is a classic eccentric halo sign. We have here this halo enhancement with this mural nodule and the adjacent edema. This patient was immunocompromised, so this is a neurotoxoplasmosis lesion. This other case here, we have a homogeneous halo in a unique lesion. The center do not enhance. We have some edema here, mass effect, and this displacement of the midline. This is an abscess. And this last case here, we have a classic pattern of subacute stroke with this giriform enhancement, which we can see in this diagnosis. So this subject is very huge, and there are lots of other things to approach, like diffusion imaging, spectroscopy, perfusion, other techniques. I could pass like all my Saturday here talking to you about this subject, but in summary, this is what I wanted to show you. Whenever we face an exam for neoplastic research, we have to keep in mind this table here, the 5 steps that we went through in this last 30 minutes. And remember to pay attention to patient's age, lesion location, its multiplicity, if it's single, if we have more than one lesion, its morphology, imaging characteristic, enhancement characteristics, and also try to exclude lesions that may mimic tumors. Always have to keep in mind these 5 steps. Last but not least, I would like to thank my neuro team at Hospital Moinhos de Ventos for all the help in making this presentation, and all the radiology department of Hospital Moinhos de Ventos for the constant support. And I invite all of you that attended this webinar to visit and follow my Instagram page with lots of neuroradiology contents that I share with you, and some cases. I invite you to know and follow my page. Enjoy. You just have to scan this QR code to go to the profile, or you can type www.instagram.com/aneuroradiologista. So one more time, I would like to thank very much the organizing committee, Diego, Fabrício, Guilherme, for the invitation, and all of you that are here watching this webinar. I hope you learned something, and I'm always available to ask some questions and answer some questions. Thank you. Stay healthy, stay safe, and have a nice weekend, everybody.
Thank you very much. Thank you very much. Excellent, excellent presentation. Very clear slides and very clear information. And we have time. Oh, thank you. We have time for some questions, but before that, let me just address some issues. I hope you are seeing my screen. Can you see it?
Yes.
Okay. So this is our web page. So just go there and visit. We have a great value course. So again, more than 30 lectures, more than 500 cases. The cases are path proven. So this is the coupon or code for the webinar. How to go, and you just go to our web page. When you go to the web page, I'm not sure. Can you see the web page now? So go in registration or register now. You can choose the module that you would like to watch, or you can do the combo, which is the best value.
Fabrício,
Yes,
We are seeing your Google Drive.
Google Drive. Okay, let me just, sorry, so let's do it again. Can you see can you see it now?
Yes.
Okay, so this is the web page. Just going back. Here you have information, sorry. You have information about our previous courses, previous lecturers, the full program here. You can have access to what we have inside and how to register. Just click registration. You can choose your module. You can choose module 1, which is on pediatric brain tumors, module 2 on adult brain tumors, module 3 if you want to learn about neuro-oncology, and we perform also a multidisciplinary review. And the best value, if you choose the 3 modules, you just click on it, and you add to the cart. And in the end, when you decide to do the course, you just click and write the coupon H2W webinar, and you have access to this 20% discount. And I have just, let's see here, in the one last announcement. I want to share my other screen. It's going to be very fast. I want to announce that on April 24th, we don't have an exact time yet. We are going to have the pleasure to have Dr. Mohan. Dr. Mohan is a neuroradiologist. He works at the HUP, which is the Hospital of the University of Pennsylvania. He's a good friend. I have the opportunity to collaborate with him, and he's going to speak about only about midline gliomas in adults. So we never think about this diagnosis in adults, and he's going to speak about all that he has learned through an extensive work that he has been conducting at HUP. And he's about to publish several papers, and he has discovered some new interesting features on these tumors, and he's going to be here next month to share his experience. And with that, we can open for questions. We have some questions that came up from the web, from WhatsApp, from the chat. Would you like to take some questions, Diego?
Okay. Yes. Okay. First of all, thanks, Marjana. Excellent talk. More than expected. We have a couple of questions if you have any time for us.
Sure. Mm-hmm.
Okay. The first question was made via WhatsApp, and it says, do you consider that contrast enhancement could be replaced by other sequences, especially in pediatric patients, or, for example, using ASL?
I don't have lots of experience with ASL in children because the machine that we use, the ASL, it's 3 Tesla, and we don't have the anesthesia apparel to do the exams there, so we don't have lots of this experience. But I believe that in some cases it is possible, yes, especially in the high vascular tumors. We have some cases of vascular malformations that we studied with ASL with good results. So I guess it is a possibility, especially in high vascular lesions.
Okay, thank you very much. There is other question. Would you recommend a time delay for T1 post-contrast imaging after the contrast?
We do 2 types of post-contrast imagings, one volumetric and one spin echo sequence. The spin echo generally is a little bit delayed in relation to the the volumetric one. And we use a gap of like 5 to 7 minutes after the injection. We do some other sequences, and after we scan the post-contrast. So I think, yes, it is helpful, especially if you have two different sequences showing the contrast enhancement. It can help, yes, especially in smaller tumors, or like nodular metastasis, that micrometastasis, it can help very much.
And I have other question that comes from WhatsApp. And do you think there is a value for the FLAIR post-contrast image in basically in metastatic workup or other kind of tumors?
For tumors, I actually don't have this experience, but we use in multiple sclerosis, and we have some cases of leptomeningeal enhancement. So I think it is very, it added some value for our diagnosis.
Okay, thank you very much.
Any other questions? Guilherme, would you like
I
to
guess that there is now more
say something
in the chat?
I just wanted to thank you all for attending. Thank Marjana for the brilliant lecture. It was
Thank you.
really good, very informative, a lot of interesting cases, very didactic. And also to thank Gerbe to put in all this effort with for these educational issues that we're working with. And that's it. Thank you very much.
Yeah, excellent. Thank you very much. And this lecture is going to be soon in our website, and probably in the next 1 or 2 days is going to be there. And after that, probably in 2 weeks, we are going to post the lecture on YouTube, so you can benefit from it as well. And thank you very much again. Thank you for watching, and thank you for staying with us.
Thank you very much for the invitation, and for everybody that that was here. Thank you very much once again, and have a great weekend.
Bye-bye. Thank you very much.
Bye-bye.
Thank you. Bye-bye.